Hello there. My name is Paul Riley. I'm from the scientific marketing team at Diagnostic Astago, and I'd like to introduce one of our Lab Week speakers that we have, and I'll let her introduce herself, and then we'll just go through a few questions to give a small preview of the upcoming webinar.
Great. Yeah, my name is Anna Merrill. I'm a clinical chemist at the University of Iowa Hospitals and Clinics, where I oversee general chemistry and also coagulation.
Okay, great. Could you just give us a short little preview about the educational webinar that you've planned to present for us for our recognition of the Medical Laboratory Professionals Week on April 19th?
Sure. So the title of the webinar will be Direct Oral Anticoagulants, Measurands, and Interferents in the Clinical Hemostasis Lab. And as that title suggests, the content of the webinar will be split into two main parts. In the first part, I'll discuss how DOACs might affect common coagulation tests. So whether or not this is happening depends on both the mechanism of action of the DOAC and also on the coag test methodology. I will also suggest strategies laboratories can take to mitigate interferences from DOACs. And then in the second part, I'll discuss why clinicians might be requesting DOAC measurements, what assays we have available to us for measuring those DOACs, and then the benefits and drawbacks of offering such testing in your lab.
Okay, yeah, that sounds really interesting. And I think that's really in line with the questions that we get regularly from people in the laboratory who are our customers. So who is the ideal target audience for this webinar then?
Sure. So I'm hoping to make the content interesting and applicable to a wide array of folks. But the audience I'm envisioning targeting with this webinar is, laboratory professionals, a variety of different lab professionals. So this could be, laboratory technologists, maybe supervisors or managers, and also lab directors who might be fielding some of these questions from the clinicians. Also physicians and trainees who are performing coagulation testing to provide patient care.
Okay, that makes sense. So you talked about DOAC measurement a little bit. What have you found in terms of challenges when communicating how these lab tests work when you're speaking with clinicians outside the laboratory?
Yeah, this is a great question. I will say my institution, there are quite a few challenges with trying to explain this testing to providers who might be ordering it. My institution for a long time did not offer measurements for DOACs, and we were kind of hesitant to bring it on board. I think a lot of that is because of some of these concerns that we had about how challenging it would be to communicate how to use the test, how to interpret them. So I can break this down into, I think, three main challenges that I encounter quite frequently. And I'm constantly trying to reiterate with providers to give them clarity about what is going on. So the first of these challenges is picking the right test, which is a struggle for a lot of coagulation testing, I feel like. But so when you think about it, if you're measuring the like apixaban or rivaroxaban, which are the most commonly prescribed DOACs, you're usually using an anti-10A based methodology. At least most labs who need to be offering rapid results are using that. And so there could be a lot of other similar sounding coagulation tests with similar names, but also have, factor 10 in the title. So in our lab, for example, we have, clot-based factor 10, we have chromogenic factor 10. Those are not the same as anti-10A based testing. And so I think getting the providers to know which test, if they decided they want to order this test, which test should they be ordering to get what they actually are wanting to get in terms of a result. So that's challenge number one. Now, challenge number two has to do, again, is kind of limited to the anti-10A based methodologies, approaches for measuring DOACs, and that has to do with some of the limitations in terms of specificity. And so any anti-10A based test is not specific for a given, drug. Like there's not an anti-10A based test specific for apixaban or rivaroxaban. We calibrate them against those drugs. But if you also happen to have heparin in the sample, that's going to be reflected in the result. And so those types of assays are not able to differentiate between direct acting 10A inhibitors and something like heparin. So that's another challenge. And then the third one is, to me, it's a post-analytical challenge. So once you've selected the right test and analyzed the sample and provided a result, what are you intending to do with that result? So there are no established therapeutic ranges for DOACs at this point, meaning
Sure.
unlike warfarin, where you monitor the INR and you adjust dosing to be effective, but not putting our patients at risk for bleeding, we don't know that information for DOAC concentrations. And so it's really challenging to know how to interpret a concentration.
Sure.
So current evidence does not really support routine monitoring of patients who are on DOACs with the intent of adjusting their dose of the medication based on that result, because we don't have established therapeutic reference or therapeutic intervals to make that change. And so in my institution, this lack of clear guidance on how to interpret the result is one of the reasons we've really tried to limit DOAC measurement to patients
Sure.
that have life-threatening bleeds that are presumed due to the anticoagulant, where they might be needing an urgent procedure and they're not sure if they need to reverse the patient, or in rare cases in patients where there's a suspicion that they might not be adhering to their therapy.
Okay. Yeah, that makes sense, really. And I really am trying to be, really recognizing how, the patience you must have when you're talking to all these clinicians outside the lab. And then what are you seeing in terms of trends? You mentioned rivaroxaban and apixaban are the most commonly used. Are people still taking warfarin at all? Are they managed by a Coumadin clinic, or what other trends are you seeing?
Sure. Yeah. So I think at our institution, just like across the United States, the growth in especially the direct 10A inhibitors, so apixaban or rivaroxaban, has been increasing over the last decade or so. And so I think it's been a while now, like for the last 10 plus years, apixaban prescriptions for a specific clinical indication, which is like non-valvular atrial fibrillation.
Sure.
Those are now for over a decade now. Those have been more commonly treated with apixaban than warfarin. So that's just one clinical indication. And most of the time, guidelines are recommending DOACs over warfarin, but there are a few important exceptions to that. So certain clinical indications, like if you're a patient with a mechanical heart valve, you should not be getting a DOAC. And if you are a patient with antiphospholipid syndrome, you should also not be getting a DOAC.
Okay.
So those are still important patient populations that need warfarin. And so my institution, we still have an anticoagulation clinic to help manage warfarin in those patients. And they are still providing a very important service. And then also not just the clinical indications where DOACs are contraindicated, but there also are still cost differences in and how much it might cost a patient to take a DOAC versus warfarin, which of course varies depending on their medical insurance and all of that. So for some patients, even if their condition could safely be treated with a DOAC, for financial reasons, they may elect warfarin over a DOAC.
Okay, yeah, that's really interesting, and I thank you for that preview of this webinar. And I think our customers in the laboratory are really going to be quite open and really thankful of this learning. So I appreciate you spending some time and helping us with this education initiative. Thank you.
Great. I'm looking forward to it.